So, what did you guys think about that intro?
That was
Did you
pretty
look at
bad,
that?
pretty awesome.
You like that for our first
Yeah,
ever podcast,
Need
going
my
through it?
lights.
I like Logan's idea of doing the lights with it, but um, yeah,
You could
I'm
flick
just
the
glad
light switch on the
Andrew's
room
here.
and trigger some epilepsy.
Oh, and Andrew's got his red light. He's in the red light district there.
just need to get my syringe flips in. That's all that I care about.
You need more lava lamps in your background, Andrew.
I know you guys are recording, but I lost my screen. That's really, oh, there it is.
There it is. He's found it. He has found his screen. Well,
Uh,
hey everyone, welcome to the C4 podcast, Critical Care Cougar Cadre, where we're going to break down the difficult topics in EMS. I'm your host, Nick Larmer, and today I'm joined by my Barton EMS instructional team, Andrew Hartel. Andrew, give him a wave. Our lead paramedic instructor, who's done it all except fly with the critical care teams, Logan Higby. Give us a wave, Logan. He's our clinical coordinator who keeps things running smoothly for our student experiences. And Jay Holmes, uh, he has the title of EMS instructor, but we got to make it a little more fancy. EMS instructor extraordinaire. And together, between the four of us, we have over 50 years of EMS experience. So today, guys, I want to dive into the topic of cardiology, the battle of the rhythms. I feel like Andrew's going to get out of his drum set at this point and just start like hammering out a riff. But the battle of the rhythms between SVT and Sinus Tach. So, Andrew, what do you think when you hear the battling between SVT and Sinus Tach? Why is there even this contentious point between the two? I mean, are they two separate rhythms?
well, I guess let's break down each one and we can kind of figure out what we're going to go with when we get there. SVT, to me, and to everybody else, is a rapid heart rate, narrow complex, one of its signature signs. It's notoriously coming up from the above the ventricles, hence the name supraventricular
And
tachycardia.
it's greater than 150, like ACLS says. Like that's what we've all taken. Greater than
Ex
150, SVT.
per some sources might vary, but it's all going to be in the same realm.
Okay.
But yeah, around 150 is where it's generally agreed. Above that is in the SVT realm.
And so when we're looking at that, but someone's got a heart rate that's a narrow complex and it's 150 beats per minute, and they're sitting in a easy chair after running 4 miles, and they just got home and they sat down and they're tacking out at 150. Why do we not call that SVT and we end up calling that sinus tach?
Good question. I think that's kind of at the heart of our debate. Um, Not really even debate. And we'll kind of go through this the further we kind of get into this. And you can just keep it simple, just in rhythm interpretation in general. I mean, textbooks have to say one thing, right? You don't buy a book and it's not just gonna say, well, maybe. I mean, unless it's a conspiracy book, right? Uh, for a medical textbook, that's generally not how they put information in
Conspiracy
there.
cardiology. I like it.
Yeah, I mean, we can come up with something like that, and we definitely can fill up a whole series. In fact, because when you start getting down to the root of all these things, I mean, honestly, some of it is just it's almost it's like redundancy with like the names or just who's funding a project or who's just what I mean. So it gets pretty deep in the woods with that, like which with what doctor is affiliated with this or which disease process or whatever. But generally, looking back at everything, I mean, this is kind of where we're standing at with anything that's tachycardic or anything with rhythm interpretation in general. It's almost at the eye of the beholder. And I'm sure as everyone in this room, this Zoom room right now, and everyone that's going to be listening in the future, They're going to understand what I'm talking about here in a second when we get to interpretation, because you put a strip in front of me, like a 12 lead or a 6-second strip, and I'm going to give you my definition, and I'll keep within the rules. I learned, and I was a good paramedic student. I learned all my rules, interpretation, and it's kind of like the laws of physics can't be broken, right?
Right.
AFib's never just regular. That's not really a thing. It'd be a different rhythm. But but it's just I can come up with a slightly different variant for my interpretation, and you're going to come up with a slightly different variant for interpretation. But I'll bet money on the table right now that we're going to treat it the same way, because we're not just going off what the ECG is telling us. We're going to look at the whole picture, which we'll talk about later in this podcast. But
Yeah.
yeah.
Logan, what do you think about this whole thing? Does this even really bother you? Do you really get worked up about this whole SVT sinus Tach issue? Where do you sit on the fence on this?
Well, when you think about it, supraventricular just means above the ventricles. Sinus tach is coming from the sinus SA node, so they could theoretically be in the same spot, right? So to me, when I look at it, it goes into all the other stuff. Like, are they just finishing that 4 mile run and it's slowly coming down, but it's just above 150, like we've all learned? Or is it like Adderall, meth, are those a part of it, medication issues? Or is it just there and it's a rhythm problem or a heart problem that needs treatment versus outside factor, I guess you could say.
Right.
No,
So
But like you said, we generally treat it the same way.
so
Sweet.
context can change. Jay,
Yeah.
context has never changed for you when it comes to treating patients, does it?
No,
Never.
no, never, no. I've always had the argument or the discussion from the fact that SVT is that overlying umbrella, if you will, of rhythms, and you
Yeah.
have your sinus tachycardia and an atrial tachycardia, whatever you want to play with. Yeah, the book says that 150 is the cutoff, but like Logan said, I've had folks that have been out exercising that have gone well over that 150 mark while they've been running the 200-meter dash. That's a natural occurring thing. The SVT, on the other hand, is typically something that's not necessarily physiological. It is more of some sort of reentrant electrical problem that we have to deal with. And the bottom line is, in my years, I'm the old guy. In my years of experience, it's always been it's SVT until I can slow it down and find out exactly where it's coming from.
Mm.
So the argument is really not that big of a deal until you get it back down to a rate that you can actually differentiate between, is it a fib or is it got a sinus P wave with it? What do you have to see in order to make that differentiation? At 150 plus, I've had cardiologists tell me that they've got to get it down slower somehow before we can even make the differentiation between what type of SVT it is.
And that's interesting. You bring up a cardiologist. We recently, my wife had to have her procedure done to have the ablation, and they sent her into what they classified as SVT. But then, I had another term that came out, and we had a paper that they handed us, and it's supraventricular tachycardia. And if you know the story between me and Andrew, I mean, I was kind of egging it on, sending him pictures like, here's what the cardiologist said.
that you were
But he was like, well, if the cardiologist said it, I guess. But
to the doctor.
doctor, doctor. But the whole aspect, though, when we went into the room and he was explaining to me, he said, "Hey, look at this. This is what we did. We went in through the thigh, we went up to the heart, we sent her into the SVT as he called it initially." And I said, is that truly what you found, or did you find something else? And he goes, are you in the medical field? And I said, well, yeah, I'm a paramedic. And he said, it was AV nodal reentry tachycardia.
Very
Um,
specific.
very specific, an AVNRT. Now, do we get to that, actually, sir, to that very specific definition in a paramedic class to where that true name is, and how was he able to figure that out? The only way he was able to truly figure out that it was an AV nodal reentry tachycardia is he was on the inside of the heart. He was on the inside and he was using ultrasound. I mean, how many of these services actually have ultrasound in Kansas? Does anybody know any service that is using point of care ultrasound?
Salina.
I'm gonna say I know
Salina?
Salina.
Yeah, I actually looked into it for our service. But it comes with protocols and a lot of red tape
Oh,
and
yeah.
everything like that. It's a long process, but yeah, I did the whole research on it and everything. They're using it for not, I wouldn't necessarily say they're using it to confirm SVT or anything like that. Like they're not getting that crazy into it. They're using it for a lot of cardiac arrest is a lot of what and
Cardiac
fasting.
arrest,
But yeah,
and also looking at the abdomen and see if there's like free floating fluid and stuff like that going on. Yeah.
I, we had a lecture from a guy from Riley County one time, and he came down and said it was talked about how it was the future, like one of the future comings of EMS, and I don't disagree. I think it's a great tool.
Yeah.
Definitely. Coming down the pipe.
I mean, if I was to give my true bucket list of things that I hope that we eventually get here at the college, it would be point of care ultrasound. At least we're teaching it to a degree.
6,500 bucks and it's yours.
6,500. Well, we just got a new ventilator, so or refurbished ventilator, and that's a little bit cheaper than the ventilator. So it's a potential. It's in the future.
It was
Um,
a lot cheaper than I thought it was going to be, to be
I
honest with you. I
know,
was way more than $6,500, but that was it.
it was like pleasantly surprising for medical equipment.
Yeah.
Like, oh,
so
reasonable.
when it comes to those pleasant surprises, I mean, you think about being in the back of the truck and you hook up your 4 lead on that patient who's sweaty and diaphoretic, and all of a sudden you have this nice little pleasant surprise. And here's this rhythm that they're tacking along at 160, and you've got a narrow complex QRS. You can't really identify a P wave or a T wave because you're seeing this little tent-like structure in between. And I feel like you kind of have this moment of like, oh my goodness, is this the rhythm that I've seen in school? Now it's time to do what I need to do. And so how do we make sure that we're recognizing that rhythm? We'll get to the point of treating it and not freezing, but how do we make sure that we recognize that rhythm and not like identify something else? I mean, we talk about context, we talk about treating the patient, not the monitor, but I mean, the monitor's showing a fast tachycardic rhythm. How do we know what we're seeing? Andrew, how do we know what we're seeing?
Well, first, let's discuss that feeling you said when you're sitting in the back of the truck. You put that monitor on, and you're alone. You're a paramedic. This is it. This is the real deal. And you see it pop up, and you're just like, like I'm not sure. So first steps are, let's be sure. We have 12 lead capabilities. 12 lead is going to give you a lot more clear, at least a lot more information. Because, and this is where I'm going with this. We're going to kind of analyze this before treatments, before any of that. We already know just by what you said, patient's pretty symptomatic, right? I mean,
Yeah.
when you're truly symptomatic, you can't hide it. And that's part of the ongoing assessment, continuing assessment as you're interacting with them. But several things, and this is going off that we know basic cardiology rules for like the different genres of or you have our atrial rhythms, ventricular rhythms, you have like your junctional rhythms, stuff like that. They all have set of rules. They all, tend to follow them. And what people don't understand is this is not really a black and white thing because you can have variables and they can interchange and go in and out of each other and things like that. And you can have like it gets deep, deep, deep in the woods. And I think that's something I want to bring up too before this, conversation gets any further that, we're talking about entry level emergency medicine. So, I mean, what we think is getting deep in the woods with this interpretation, I mean, it's an iceberg, really. And we're just
Right.
sitting on top of the flag. We don't know how, I mean, just by your story, Nick, I mean, going through it with, with your wife and, what the doctor or the cardiologist was saying, how very specific type, and the only reason you would know that is, you got to go inside, you got to go see it, you got to see, get a little
Right.
bit more information. That being said, you know, you have this on the monitor. It's fast. Okay, right there. You could take a breath. All right. I know it's going to be one of my tacky subjects, so we can rule out all the Brady stuff, right? So I know that's not helping your mind right now, but I mean, trust me, when you're a paramedic, especially a new paramedic, and you have all this stuff floating through your head, it's nice when you can kind of say, well, it's not that, and you can kind of, focus in a little bit more. So we know it's really fast, right? And we were good, and we got our 12 lead, and we confirmed. Now it's, like we said, it's kind of just going through the steps. And this is the whole point of it's repetition. Nobody likes hearing that. Nobody likes, everyone wants to, like, well, if I listen to this podcast or if I do this, or if I try this technique, I'm going to get it. Those are all great things, but honestly, it's like everything else in life. Unfortunately, the most non-fun, mundane way is how you're going to get, improve yourself. So repetition this is why, you do like your book and you just practice because these rules start to get ingrained in your head. And then you can start ruling stuff out. Yeah, I know it's fast. And then your eyes immediately go to, you look at that QRS complex. It's narrow, stuff like that. Because you already know if you get that information, it's going to narrow it down even. And all you're doing right now is just making your job easier, mentally with your assessment. And, you do this almost instinctively as you learn it. You don't even know you're doing it. But you're okay. It's a really fast, it's a narrow complex tachycardia, right? Right there. We have gotten our window down pretty close. Logan brought something up earlier too, and I do want to dive in, but we have a whole class to talk about this stuff. But it's like, a fast heart rate's a fast heart rate. Like, Jason, what's the context here? What is it relative to? Like, were they sitting there and it was this fast? Is that the only issue? I mean, it's just, are they bleeding out? And this is just the body compensating, like, is this, the tachycardia is supposed to be there? Et cetera, et cetera, et cetera. I mean, we'll get to that, but that's not the topic. We're just talking about the rhythm itself. So all we know it's narrow, it's narrow or it's wide. We'll say in this scenario, we're talking about SVT, it's narrow, it's fast. Okay, there's only so many things it can be at this point. And this is where the conversation gets kind of, you take what it as, I want each individual, person who's kind of dropping in on this to make it their own. But this is where this kind of gets forked in the road. Some people like, they want the text, hey, you said it was over 150, the, narrow complex, and they look symptomatic. It doesn't really matter what it is, we're going to treat it as such, hence the SVT, right? Like Jay brought up, an umbrella term, right? It doesn't matter because we don't really know what it is because if we slow it down enough, it could be AFib, which as we'll talk about later is, treated slightly different than if it was just a sinus tach or, a junctional rhythm or, something like, of that nature. So it varies a little bit. But then you also know that when you pull back, a fast heart, it's a fast heart rate. And a wise man once told me, it's like, don't overthink things. If it's going too fast, slow it down. So that's all we're doing. And you got to kind of step back on that. But for the rhythm interpretation, it gets to it. And that's where SVT comes in because, we'll talk about this, as we kind of evolve with our cardiology skills and getting more comfortable with it. But if you really look at it, I kind of compare it to like, do you like Mexican food?
Oh, I
you like
like Mexican food,
I
tacos.
love Mexican food, but if you really, sometimes they always kind of, you're using the same core ingredients, right? It's always just like some type of protein, usually like rice, stuff like cheese, and they, change it in different ways, makes it a completely different dish. But I mean, at the core, it's the same thing. And that's
Mm,
kind of like how I'm looking at, with SVT and stuff. I mean, we're going to dissect it. I mean, it's to say if there's P waves there, then it has to be a very fast, sinus tach versus, it can be, AFib with, RVR, right? Rapid ventricular response. It's just basically AFib that's so fast, it's appears regular because I mean it's fast. But obviously that's a different, it's a different pathophysiology with that and how we're going to treat it, or at least how it responds to treatment, but not by much. I mean, all our initial treatments are going to be the same. I mean, we're just going to generally slow it down, like especially with narrow complex, kind of it keeps it in that arena. Like we know a vagal maneuver is pretty much going to at least maybe be effective for any of these conditions because it's a narrow complex. I mean, we know that that's where the atria is going to respond, obviously with that vagal tone, stuff like that. So it doesn't really matter if it's, AFib or a junctional tachycardia or, sinus tach. It doesn't matter at that point. It's going to respond the same because it's all originally from the same spot. So I think the root of this conversation is just kind of almost getting down to documentation. It's just basically how do you interpret what you're seeing on paper, not how you're really treating it. Sorry, kind of tangent there.
No, I like that. So it makes me think though, Logan, when you're teaching students at the AEMT level, you know, you teaching them to look at pictures so that they can document their pictures, like that textbook picture. I mean, is that a good way to be teaching these students, or at least be working through learning our rhythms? Andrew mentioned that we need to like hammer it in, and we've got to have that repetition. We got to be looking for it. But I mean, is pictures the best way to be learning this?
I think, and we kind of covered this in our AMLS class, I think it's a really good idea to have a basis. If you see 150, it should be on your differential diagnosis. And you should have an understanding of what it looks like. I mean, you can't get a real life example of it until you're living it. And we hope that that's an internship, but for the most part, it's in the real world when you're by yourself in the back of the ambulance. So I think it's a good idea to have a picture of it in your mind and understand kind of what it looks like. I've had some that look like STEMIs, and you're thinking about it, and then you look at the rhythm, and you're like, well, either way, I can have an idea and I can have multiple things on my palette of differential diagnosis, but I've seen SVT before. Is this what it looks like? Is this not what it looks like? And then back to Andrew's rules, we have our rules. And so you break down your EKG through the rules, and then you can find out and or slow it down. So all of our different techniques to slow it down from simple to major, slowing it down, and then you can get an underlying rhythm, whether that's sinus, atrial, junctional, whatever it may be. So I think it's a good idea to have a picture of it and understand what it should look like.
Yes.
And one of the best things I ever saw for cardio like EKG interpretation was from Foam Frat, and they said understand what normal looks like, and then you can go off of from there. And so if you understand and have a really good picture of what normal looks like for every rhythm, whether it's a normal rhythm or not, what that normal rhythm should, you can compare these road rash or, patient movement or whatever it may be. You can take that normal picture in your head, whether it's normal sinus or we have normal what SVT should look like. And you can compare it to what normal is and find the oddities. Is it an oddity because it's not actually SVT? Or is it an oddity because you're bouncing on the road or whatever it may be? And you can compare all of these different facts that you have and all of this different education, whether it's books, your class, your 6-second EKG thing that we play with in class to teach students, or just a thing you saw on Facebook. It doesn't matter if you know what normal looks like, you can base that off of and go from there and farther down the pipeline.
And I can't tell you how many hundreds and hundreds of books and pages of books that I've gone through to look at different rhythms. And yeah, you're not going to be able to recreate them on that monitor with the rhythm generator at any given time, but pick up a couple of those books and work through those books. And like you said, there's normal in there, and then there's all kinds of variations of other things in there too. And that helps with the repetition of we're going to start out, is it fast, is it slow? I'm old school. I get out a piece of paper, I have to print things off and I have to mark things out and say, does this walk out, or is it irregular? It looks regular on the monitor. I got to print it off.
Yeah.
Once you get to that 150 mark, they all look regular because electricity and technology will not allow you to see it with the naked eye at that speed. You have to slow it down.
Just our books alone that we use for paramedic class look different.
Yep.
Right.
So, I mean, it could be a world-renowned cardiologist or author or whoever writes this book, and they could look a little bit different than the next world-renowned author. So,
Yep.
I mean, we're using these at the college level to teach, and they still look different.
So what I'm hearing from everybody is we can look at these rhythms all day long. We can practice for years. But when it comes down to the context, it comes down to how fast it is and going through our steps. But we've also got to kind of take into that context the patient's presentation and symptoms.
Yep.
If they're sitting in the easy chair and they haven't moved for the last 4 hours, and now they're tacking out at 170, that's a different context and a different presentation than the person that just ran a marathon. And I think that comes down to a good patient history and a good patient assessment to try to obtain that. So it's not just like, hey, we slap on a 4 lead and a 12 lead to get that, but we've also got to get some history quick enough to discern, our treatment pathway of what we're going to do, and also not get tunnel vision that we see SVT and everybody's getting adenosine, or that everybody's getting cardiosem, or not that this is a worst case scenario, because I'd like to see more medics pulling the trigger if adenosine's not working, that they feel comfortable enough to apply the pads and cardiovert. I mean, what are some symptoms that you all think are like what is that symptom you look for? Like when you see a fast heart rate and it's like that one symptom that you've seen before, it's like reoccurring that you think, man, I see that one symptom or that sign. I shouldn't say you see that symptom. You can't really see symptoms. Come on, let's be honest. They're going to tell you if I can see the inside of people's brains. But the sign, what's that one sign you see, or what's that one thing that somebody tells you as a symptom, and you go, wait a second here, we've got a problem. I'm gonna start with Jay. Jay, go ahead.
Andrew, does the book say years ago, if they're unstable, shock them? Synchronized cardio version, they're unstable. And that could mean that they're sweaty, diaphoretic, maybe a little altered. Just shock them. That's the way it was. If there's something that says that they're symptomatic, you shock them. That's what the protocol or the rule is. My idea, or the way that I approach it, is, are they going to remember that I shocked them? And if they remember that I lit them up before and after, that's kind of one of my preferences that I say, I think if they're going to remember, they're still alert, but they're not feeling real great, let's slow this down chemically and see if what we've got, and see if that works first before I go to that. I don't want to call it extreme, because it's not an extreme. It happens. But if they're going to remember it, then I think I'm going to start out vagal maneuvers and some medicine before I go to that mechanical electrical intervention, in my book, my opinion.
You mean you're going to try to do less harm to follow the Hippocratic Oath before you go to something more extreme?
Just throwing that out there, boss.
Logan, what do you think?
So, first off, it's not something that I've ever done in the field.
Really?
So I've seen it twice in the hospital during my clinicals, and both times I mean, we have our red box symptoms per ACLS that kind of always paid attention to and remembered for it just in case I ever have to do. And it's something that I walk myself through regularly because I've never done it. And the time it comes, they're going to need it. So I need to be ready to do it. But the one thing I saw, and again, it's a sample size of 2. So Not saying it's perfect, but the thing that was consistent between both people was impending doom. They
Mm,
felt like their heart was going to explode.
mm,
I've heard that, been there, seen that. Yes, I can get you there.
So that's something that I've always cautiously made sure that I pay attention to. Like kind of in our sample history and all that other stuff, like you're asking these questions, are they able to answer them in the first place, or is it just that bad? And second, what is it relating to? Are they constantly coming back to my heart's gonna explode, my heart's gonna explode, my heart's gonna explode? And you're not really getting, they could care less about what they're allergic to, their heart's gonna explode. Like those are things that are important to me.
right.
Alongside ACLS and protocols and all that stuff. But the extra stuff that experience has taught me is impending doom.
Mm.
Absolutely.
Mr. Hartzell, what do you think?
I think a lot of things, Nick. I think a lot of things.
I can only imagine.
Well, before I tangent off here, my quick answer to that is like I guess my trigger symptom or sign or symptom where I kind of push it into gear, or I guess it actually, I can actually feel my adrenaline start to get released, is like that. And if you've whoever's listening or watching, or if you guys know what I'm talking about, not just, diaphoretic, but that real diaphoresis, that like sticky, slimy, that
Mm,
just almost corpse looking, like that's you can't fake that, and you're seeing this like, you can see this in the middle of the winter, it could be 20 degrees out, and this person is just once that's to me, in my experience, that's always like, that's I'm like, uh-oh, like the pump's about to the levee's gonna break there, like, and that kind of gets me moving. That's kind of my big one. And I totally agree with you guys too, because usually if they look like that, they're also gonna have that impending doom, or that just uh
And that's alongside that, like sitting in the chair all day. Like they didn't just run on the treadmill and you're at the
yeah,
gym thing.
it's,
'Cause
it's
it's
like
not the same sweat. I know what you're talking about. It's not the same
It's
sweat.
unnatural.
no, it
It's
isn't.
Yeah.
Well, and even alongside the impending doom on our side, or at least my side, with having experienced, personally, not personally, but with my spouse, you know, um, she's got into SVT, and there I said it again, SVT. She's gone into that 4 times, and she's had adenosine 3 of the 4, and she's never had to have been cardioverted. And so that already kind of gives you guys an insight that she wasn't as unstable that they felt like they needed to, as I remember, it's if it's unstable, it gets the cable, um, or light them up with electricity. But the aspect for her was like the phone calls, just their tone in their voice, not an impending doom like in their face, the facial expression, the typical sign that we talk about is the facial expression, but also their voice. Now we're not always going to be able to pick that up, but I mean, when she would call me, I would know, like, hey, my heart went into SVT again. Like, you could just kind of hear like this heaviness in her voice. And the other aspect was just, it was like she couldn't quite get a bigger breath.
Mm.
Her heart was going faster, and she would just say, I just feel like I'm a little short of breath. Heart's racing. It feels like I'm running around the block, but I'm standing still. And I mean, one of the times we went 6 hours. It was just because of the ER we were in, for her. She was at that range of 140. She's
Right
at
on.
140, and she's presenting somewhat symptomatic. And I told the physicians, like, hey, she was at 147, 148 the last time, and we gave her adenosine. It slowed it down, and she was better. But because she wasn't at 150, and they said that to me, if she'd be at 150, 155, we'd be able to give her adenosine. But because she's not, we're going to have to do something else. And the concern there for me is how much weight does that one number carry when it comes to this patient that is presenting with some symptoms? They may not be fully symptomatic, like Jay said, where we got to light them up, but they're tachycardic, yes. So the SVT sinus tach, I mean, there's sinus tach that's a symptomatic sinus tach. How are we going to treat that symptomatic sinus tach? Because it's not SVT. Because if we're going to really put it the brass tacks, 150 and above, I mean, how are we going to really treat this person that's presenting in front of us? And I think that kind of takes us into our next thing is our treatment approaches. How do we go about treating these rhythms?
If I kind of stepping back just a tad, getting into the treating, I kind of want to go off of you getting to that point, and Jay brought it up earlier, and then you brought it up too, and I just want to say, for uh, paramedicine in general, especially the assessment that where you're developing throughout class and internship, and this is why all this stuff like all the clinicals and like just as many patients exposure, especially like cardiology patients, when you're doing like your ER rotations or you're sitting on the ambulance, internship, and you and your preceptor, you feel like I should quiz myself. It's always we always tend to go, either there's popular categories, right? And cardiology is always one of them. It's always up there, along with like drugs and math, just because those are the ones that everyone wants to keep repeating because you get put in situations like you're just saying, and we got to remember too, like protocols are written and like and even the hospitals and stuff like that. I mean, you have to. It's like I said, it's like at some point you have to translate this, 3D idea to 2D, right? You have to put this on paper, right? Everyone's different. Everyone's, metabolic rates and, physiology. Everyone's slightly different and variable. But I mean, but you have to put something, you have to put a rule down, right? There has to be a line in the sand for this works here, this works here. So that's why you'll see stuff like, oh, if it's not, they're at 148, they're not at 150, and the whole general idea is that, that drug generally works really well with people with rates over 150 60% of the time or something like that. So that's kind of, you get in that little box area where it almost becomes like a legal versus, like, the hospital wants to, obviously stay out of trouble and, stay on the right side of the legal thing, which we all do, especially practicing,
Right.
out there and with medicine and stuff like that. It can be kind of, the way a whole you have a whole couple chapters of it, in every single textbook about it. But that's one of the things that we run into, and we run that EMS runs into that a lot, like a lot. We get kind of these stucky, like gray areas, and that's kind of like the hospitals get into that too, where we can kind of get around that. And this is where I actually view an assessment more of an art form than just that. And this is why if you try to do cookbook medicine, it's not. It has its place, when we get up, to those bizarre once in a lifetime, maybe twice in a career thing, and then you're like, what is this? Special populations, stuff like that, But for the most part, cookbook medicine doesn't really work for the modern paramedic with the critical thinking differential diagnosis. It will just put you in a box and you'll never get out of it, and you'll miss
Yeah.
certain things. So let's talk about this. Like you go there, you have tachycardia, stuff like, we know we have to go with that. We're going off of, and this is where I'm going off what Jay said earlier. You can be medium sick. You can be really big sick. You can be, maybe they have a SVT going on. They don't even know it. Like you're there for like a swollen ankle and you just happen to put them on just because you like practicing looking at normal rhythms, like Logan said. So you just get them on everybody and you go, oh, wait a second. Is that normal for you? You might find it by mistake. And this is all where I'm coming from. It's like, you got to figure out, are they sick from this? Or what is like you asked, what is your big thing? Like mine's that diaphoresis. You can't fake that. You can't fake when your pump's failing you and your body is like, oh no, and it's coring up, right? You literally see that pouring out of somebody. Like, so it was, they can't pull a fast one on you. You're not going to
Right.
be wrong. Um, but same thing, like, I might, there's no reason that you have to go like, oh, SVT, it's under 150 and they're slightly uncomfortable with chest pain. I got to shock them. Like, that's not a thing too. Like, no, nope, nope. Like, like this is why they give you the big five, right? And ACLS. I know everyone has their little, opinion on AHA stuff, and it is, and then, you should always pick up from different sources. But I mean, they have a good core, and the good core is like, the big five. They have, which makes them, critically sick, where you have to intervene with the most extreme measure, which would be electricity. It's like chest pain, signs of shock, was altered mental status,
Shortness of breath,
shortness of breath,
Hypotension.
that signs of
hypotension.
CHF, which all of these kind of bleed together to signs of cardiogenic shock, right? I mean, they're all evolving around the same bus here. Like
Right.
who are we kidding? And it's almost like you got, because how many times, and I guarantee everyone in this room sitting here is like, because if the textbook told you to, and you ran this patient, you should have been pacing or cardioverting them, but you didn't, because it's not like it is, and it's real life. They're pretty darn stable. Maybe a little adenosine fixed them up. Maybe didn't fix it, but it got them to the point where they're perfusing enough, right? Their skin starts to pink up. They're talking to you. They're feeling better. Like that's, obviously you want to give them to higher. I mean, they need to see a cardiologist. So we're not going to sit there and fix it. Everything we do is just a big giant band-aid. Going into that fixing, this is where it becomes quite easy, honestly, because once you get comfortable with understanding what it is, and you've narrowed it down, and it is the rhythm and it's too fast, there's only certain amount of things you can do. Like, so we can either use the body itself, right? It's kind of like, hey, vagal down, use what you got, because you have your own
Right.
mechanism. Try that, see if it works, and then we can get, all we're doing from there on is just getting a little bit more, just helping out a little more. And then we get kind of like the pharmacology, right? The adenosine we talked about, and we'll talk about this a lot, and you'll hear it. I mean, it's like one of the main drugs we talk about in paramedic. That's like one of the, you know, everyone knows that, even if you're not a paramedic, right? That's the famous one. Makes your heart stop, which is all, once you get to know the drug a little bit more, that's not necessarily how it works. But
Right.
it's a great tool for it, and it's designed almost perfectly to get that effect that almost yeah, it's uncomfortable. Anything like, I mean, all these procedures to a certain degree are uncomfortable, but for risk and reward, it works really well. Same with cardiosm, but cardiosm, obviously it's more targeted towards AFib with RVR and stuff like that. Which, by the way, how would you know if it's going so fast? You can't determine if it has P waves or not or anything, and that's kind of the whole point of this debate. But that's also an option, we kind of go up that, even it's like maybe some slight fluid bolus, stuff like that. That's been talked about, and that's been, in some actual counties, they go to fluid boluses for any arrhythmias like this, especially tachycardic arrhythmias, because they're showing that they actually help just by, upping basically the pressure that return pressure to the heart, stuff like that, kind of getting shaking the cage in a metaphorical sense. It's actually kind of helping it reset, slow down, get those like really active sites maybe calm down a little bit, and getting something that's a little bit more generally manageable for rhythm wise. And you have to give drugs, right? You gave salt water, and that's easy, right? I mean, that's all you
Give them
did.
fluids. Make
That's
everything better.
so, and then, we get to electricity and stuff like that, which, we're talking about cardioversion, which you basically control alt delete, which we all know that's the last thing you want to do to your computer when you're like working on it and you're trying, and you're just like, you get to the point now you have to shut it down and start all the way up.
Shut it down.
We kind of wait on that one because it is a little bit more drastic, but there's the thing with that, if it's needed, you got to do it. Here's another
Right.
thing, if, it's totally frozen and stuck, I'm not going to go, well, maybe I should hit, escape a couple more times. No, you're just wasting time at this point. Like we have to,
At some
so
point, you've got to be able to pull that trigger,
absolutely.
and I think Jay probably be able to speak more so like the amount of times, from an early career of being hesitant to pull that trigger to getting to where it's like, I've been through this multiple times. I'm sorry. We're just gonna have to do it. You're gonna have to be comfortable with the uncomfortable.
Well, and in my experience or my times that I've got to do it, I'm here to tell you that I would rather still to this day, I would rather push the button than push the med, because there is that, you push the button, deliver the shock, the cardio version, you deliver the electricity, it's over. It's done. That's
Mhm.
it.
Yep.
The adenosine still has that 10 to 30 seconds of
That half-life.
what are we
Yeah.
doing? Come on, start back
Yeah.
up. And
Kind of
it's
almost want that instant feedback.
yes.
Yeah.
The first time that I gave adenosine, I pushed it. I did the two adenosine and then the flush behind it right away. And I'm expecting the monitor to immediately go flatline. And it's like 2-3 seconds, it's still just banging along, and I'm going, why is it not working? And then it hit. And then the gal that I was giving it to was like, oh, that sucks. And then of course I'm going, yeah, it really sucks. Come on, start back up. And of course it started back up. Now, did it stay? No, because it was atrial, it wasn't sinus. But we used that as our diagnostic tool
Yes.
Yeah.
to figure out how, because she was one of those that we bared down, it wouldn't change it at all. Now,
Yeah.
I know you're not to that point that I need to shock you, but how am I going? At that time, we only had one or two tools in the toolbox,
Right.
and so let's give 6 of adenosine, and we'll do a really good job of recording during that, and then hopefully, or it'll slow it down. And if it's sinus, we don't have to do anything more. But if it speeds back up, at least it's slowed down long enough for us to differentiate, is that a sinus
Right.
origination, or is it something atrial that we can't do? In other words, we're going to have to switch gears or try different medicines. So,
And I think the other thing that I've experienced on my side, with my spouse is just the fact that, people talk about being kicked in the chest or that punch in the chest or whatever. And we never experienced like the sudden stoppage that people talk about with adenosine, like it stopped and like there was a flat line and it was like for an hour and then, oh my gosh, they came back from the dead. No, it wasn't anything drastic. It generally slowed down, but she did feel like there was somewhat of a pressure um,
I've
that hit the heart, when the adenosine got in there.
Oh yeah.
I've had it. I've had several patients tell me it's like when you're driving along and then all of a sudden the roller coaster, the floor drops out.
Mm,
Oh my gosh! Or it's a real heavy. It's one
Free
of those
falling.
sudden uh, altitude or elevation changes. A sudden drop in an elevator or something like that. It's like they're totally freaked out by it.
right.
So, and I get it. I mean, you're sitting in your living room chair at home, and all of a sudden my heart stops. So, but
So I
I've
guess
I've had them come out swinging too.
I guess at this
That
point
again, and so.
we're getting close on time here, so I think it's time we kind of wrap it up with some closing thoughts here. Logan, he had to go save the day as the clinical coordinator, and take care of things, and that's understandable. We all are doing multiple things here, but I want to kind of wrap up with some kind of closing thoughts. Make sure there's some take home points here. So I think, and correct me if I'm wrong, you two. But it really, SVT is a good umbrella term that we can utilize when we don't know what it is. Sinus tach is getting to be more of a specific rhythm, name for what it is. We might use it more so on the patients that their presentation isn't congruent with a symptomatic patient that's having an actual issue. But and really we need to get down to the ultimate, what is that underlying rhythm? What is that problem that's presenting here? And then also when it comes to quote unquote pulling the trigger on our treatment, starting out a little bit easier, depending on, their presentation. Like if they're super sick, as Andrew said, like if they're big sick, big medicine, little sick, little medicine. So, finding that differentiated medicine of when do we do the adenosine or the cardiazem, or, when do we, and then the other thing that we got to remember in all of this is we've still got to be able to follow protocol. Because your protocol may want you to try a vagal maneuver twice, but you work for another service that they want you to do it once. And we still got to remember at the end of the day, we're not doctors, not a doctor,
A doctor.
not a doctor, but
Recommend you some doctors, but I'm not a doctor.
yeah, there you go. But we gotta kind of keep that in mind. So I think one thing that I'll definitely take away is just kind of that uh, the idea of Mexican food. I really like your analogy with Mexican food,
I'm
Andrew.
just hungry.
I am kind of hungry. I kind of might have skipped lunch or something today, but when it comes to cardiology, we deal with Mexican food. It's still the same components. We're just changing how it presents itself.
And it can be
And
drastically different, but I mean, it's the same thing.
yeah,
You're gonna eat it the same way,
yeah,
but you can't
it,
call it
it
the same thing. Quesadilla is not a burrito. That's just not work.
quesadilla is not a burrito.
You'd be
Uh,
wrong.
Jay, what's one thing you're going to take away?
There's a thousand different ways to skin a cat, and we just hit on a few of them today.
Oh,
Yeah,
yeah.
The bottom line is study, study, study. Find out. I like the deal of study what's normal, so you can be quicker to say that's not normal. That doesn't look right. Um, but yeah, repetition on. Uh, I mean, half the old analogy in the fire service is the first 30 seconds is set up on a fire scene will dictate the next hour of operation. Do your homework, get the first 30 seconds to a minute. If it takes you 2 minutes, it doesn't matter. Get the rhythm right so that it does not mess up treatments down the road. Because once you've started kind of down that path, there's times it's hard to get back. Yep. So yeah, study what's normal. Look at rhythms. I've spent so much time still to this day digging through books and talking to friends, and we share rhythm strips. We look at stuff. What is this? What is that? This is what I ran on the call today. So yeah, just somebody's going to show me something tomorrow. I'm not going to know what it is, or I'm going to be like, well, I haven't seen that before. So
It's kind of the fun of it, though, too.
It is. It is. It's like, man,
it gets old.
I
Yeah.
bet you can't show me something I haven't seen before. Surprise!
Yeah, and you're like, oh,
Yeah,
the heck?
yeah. I thought I knew everything. I guess I don't. So, but
Andrew,
guys,
what's a closing thought you want to give to your students when it comes to this cardiology and SVT, sinus tach, and everything in between?
I mean, first and foremost, I mean, keep the conversation open, like Jay said. Just have an open mind. Don't get set in, like, I mean, always be willing to learn and get someone else's perspective on it. Because you find when like you start doing that and really trying to open up, it's going just to improve your EMS game more than anything. Because I mean, all you're doing is just cultivating knowledge at this point. But another thing is, trust your assessment. I mean, this is kind of the whole point of you going to class, and the whole point of you doing all this is, I mean, yeah, you get to like learn the skills, and they're cool. Ultimately, it's going back to your main assessment and kind of just, reading the patient, reading the room, kind of seeing why, like why is this rhythm generating? Is this person like really symptomatic from it? Is this rhythm causing it? Is a rhythm even the main issue, or is it just manifesting because something else is going on? And the body's trying to compensate. Listen to your patient's body. Not even, and I don't mean just physically, like when you take lung sounds and heart tones and all that, but I mean just like watch how they're talking to you, communicating. Normal situations. Like my favorite analogy is like if it's 3 o'clock in the morning, you get called to that respiratory call, 3 o'clock in the morning, you go and there's middle of the night and the whole room's just lit up now because there's a bunch of firefighters and cops and there's paramedics and stuff, and that person's still just staring at the wall, just concentrating on breathing, just staring through this whole commotion. Like, do you think that's normal? Like, if I had a bunch of people show up in the middle of the night at my house, it'd be kind of excited, and like, so that's telling you right there, like, there's something wrong, kind of, and just what you've been practicing and just going over and over and over, and all this whole point is all this pathophysiology and making you explain the why of something is, so when you get in that situation, you go, okay, this is what's happening. Obviously, they're putting a lot of energy into breathing or whatever, or this is the rhythm causing this. this is, this is the symptoms that are manifesting, and they only manifest when they have lack of oxygen or this. You start putting the puzzle pieces a little bit together, and it kind of, yeah, like Jay said, like, and we're all human too. So it's, it's EMS is not perfect, unfortunately. Even, no matter how seasoned or, veteran someone is, I mean, we make mistakes sometimes, but, and that's okay. And the point is to recognize those mistakes, kind of learn from them, and, like, this is why we have these extended lectures on, and debates, and we talk about these
Right.
rhythms. It's a common thing for, I mean, you're human. I mean, there's a lot of stuff you have to, and everyone's going to be, it's just, it's just trying to give you, here's the basic rules. But honestly, the best approach is just keep knowing what's normal. Like Jay said, just know what's normal. Just look at everything you possibly can, and everyone gets put on the monitor. Just overexpose yourself with it, and you'll be surprised. You'll start picking up on things and noticing things, and and it helps ultimately your assessment, your overall treatment for your patients. So.
Well, that concludes another, I guess I shouldn't say another, the very first C4 podcast with the Critical Care Cougar Cadre. We appreciate you taking the time and listening to us, and look forward to future conversations. Who knows? Maybe the next conversation might be something in regards to should we use a child BVM for everybody? Um, or does it really matter our attitude in the back of the truck? Or what about that paragod that walks in the back that walks on water? So affective domain doesn't really have a place in EMS, does it?
I
um,
mean, we talk about Logan even though he's not here. I mean,
so but that concludes it, and hope you guys enjoyed this, and we'll see you guys on the flip side next time. See you later.
Take care.